for the IPNA endorsed Webmaster Series 2021. So we have entered into webinar 6. Today we have two eminent speakers, Dr. Susan Uthup and Dr. Anil Vasudevan. The first speaker is Dr. Susan Uthup. Dr. Susan Uthup is a MD DCH DNB completed from KEM Hospital, and she has completed a DM Pediatric Nephrology and DNB Nephrology from Government Medical College of Trivandrum, and she is currently a professor and head of the Department of Pediatric Nephrology at SAT Hospital, Trivandrum. And she is also a honorary consultant pediatric nephrologist at Sri Chitra Institute of Sciences and Technology. She has received n number of awards and honors to add on to it. She has n number of publications on international journals. She is also a member draft committee of ISPN guidelines, and she is a coordinator of ISN SRC program SAT with Cincinnati Hospital, US. And to add on to her awards and honors, she's received n number of gold medals right from her undergraduation days to her completion of DNB nephrology and DM nephrology. Over to Dr. Susan, madam, to deliver a talk on steroid resistant and steroid sensitive nephrotic syndrome and update. Over to you, madam.
My slides, can you hear me? Yeah. Thank you, Dr. Nammalwar sir and Dr. Kalaivani for this august opportunity. And good evening, all of you. I would like to, I will be in the next 40 minutes or so, I will be dealing with steroid sensitive and steroid resistant nephrotic syndrome, the recent updates we will be discussing. So to start with, we have to have the introduction on the topic followed by the podocyte biology we will be discussing a bit. And in the recent years, a lot of development has happened in the pathophysiology, how everything is happening, how the proteinuria is occurring, and what is happening at the level of the nephron is being deciphered. So we will be touching upon that, and then finally we will be just dealing a little bit with the current guidelines on the management of steroid sensitive and steroid resistant nephrotic syndrome. So this idiopathic nephrotic syndrome in children is a heterogeneous disorder. It is characterized by a dysfunction of the normal size and charge selective glomerular filtration barrier, with resulting in the loss of large amount of protein, especially albumin, into urine. And for the last so many years, the idiopathic nephrotic syndrome is considered as a spectrum, and it ranging from minimal change disease to FSGS. 80 to 90% of nephrotic syndrome in children, the idiopathic variety is minimal change disease. And if you go to the adults, it is 10 to 15%. And based on the clinical pattern in which we see the disease, we will be having the non-relapsing or infrequently relapsing, frequently relapsing, steroid-dependent and steroid-resistant variants of nephrotic syndrome spanning over the spectrum from MCD to FSGS. And this highly sensitive variety, which is considered as very benign, and the malignant or rapidly progressive treatment unresponsive steroid-resistant nephrotic syndrome on the other end is actually showing the idiopathic nephrotic syndrome in children. And we also see a lot of secondary nephrotic syndrome in children, secondary to viral infections, fungal infections, malignancy, and also drug-induced varieties. And for the last so many decades, we have been all the time talking about steroid sensitive and resistant nephrotic syndrome and the histopathology, which is showing minimal change disease, diffuse mesangial hypercellularity, then membranoproliferative, membranous, and the more difficult one, that is the focal segmental glomerulosclerosis. But we were not knowing why these diseases were actually all this, the spectrum is behaving in a totally different manner. The FSGS variety, which is only 10 to 15% of nephrotic syndrome in children, can be presenting like a steroid-dependent or steroid-resistant disease, and the steroid-resistant disease is associated with risk of end-stage renal disease and even recurring after the transplantation, so that the disease all the time remain and we don't know what to do with it. And on the other hand, we have a good response to steroid, good prognostic variety, that is the minimal change nephrotic syndrome. And in the recent years, the recent perspectives have actually given a lot of light to the pathophysiology, and new stratification of nephrotic syndrome happened. And this is a novel molecular stratification system which is actually looking at nephrotic syndrome from two different angles. One is an immune-mediated disease, and the other is a genetic nephrotic syndrome, which is non-immune mediated. So the immune-mediated variety will be associated with circulating factors, which we call as circulating factor disease, and the other is without circulating factors. And so, going to the pathophysiology, let us first see what is happening at the glomerular filtration barrier. The glomerular filtration barrier actually, which is the filtration unit of the nephron, which is actually filtering around 120 ml per minute of blood a day. Filtration is happening, and the ultrafiltrate which is getting collected, if you can quantify, only 1% of it is actually coming out as urine, whereas the rest of it is reabsorbed at the tubule. And in this glomerular filtration, whatever is happening, actually we are not losing the protein in urine or the formed elements that are there in the blood or our cells. So this is happening because of the filtration barrier, which is formed of three interacting layers. One is the fenestrated endothelium, which is there, and then there is the trilaminar glomerular basement membrane, or GBM, which is there, as well as an outer podocyte layer, which is there. And podocyte is actually a wonder cell. It is a highly specialized epithelial cell. It is actually mesenchymal in origin, and as it matures, it becomes a specialized epithelial cell with interdigitating food processes. And these interdigitating food processes, the digitations will finally form the slit diaphragm. And slit diaphragm is a unique multi-protein cell junction structure through which the regulation of podocyte function is controlling, and through the regulation of podocyte function is controlling the ultrafiltration. So let us look at the podocyte. Podocyte is a specialized with the nucleus and the tentacles which are going all over, with the primary as well as secondary processes which are there and which are interdigitating. And finally, you can see that the filtration slit diaphragm, how it is acting like a zipper with the pedicels. Pedicel means little feet, and it is such a unique structure that it is allowing only the this size selective barrier is there, only small molecules. But if we are having only the size selective barrier of the slit diaphragm, the size of which is 4 nanometer, we will be losing all the albumin in our blood in few hours time. So there is a charge selective barrier as well. And this is the glomerular filtration barrier ultrastructure that can be explained. We have got the slit pore, which is guarded by so many proteins, and Dr. Anil will be dealing with this in detail when he will be dealing with the genetic nephrotic syndrome. So I am not going into the intricacies of this glomerular filtration barrier. So this pathogenesis of nephrotic syndrome has remained an enigma over so many years, and we are not really understanding why some children respond so well while some other children are having very difficult disease. Anyway, there is a persistent dysfunction of the normal size and charge selective glomerular filtration barrier with a resultant loss of protein into urine. And why it happens, what is the etiology, how it is happening, all of this is remaining uncertain. And starting from 1956, the immune dysfunction has been thought of, and the Shalhoub hypothesis came in 1974 when T cells were actually considered as the major player. And the dysfunction of the T cells telling that it is not the kidney which is at fault, but it is our immune system that is at fault. But what is the evidence? And over the years, lot of observations have come up. So this is a highly regulated immune model, that is Shalhoub hypothesis, and the old paradigm for the pathogenesis of MCD. A T cell derived circulating factor may be responsible for nephrotic syndrome. And the evidence as to this is remission of nephrotic syndrome minimal change disease occurs after measles, a high risk of minimal change disease in children with atopy who are having an exaggerated Th2 response, and MCD occurs more frequently in B-cell lymphomas, and this MCD is responsive to immunosuppression with steroid and alkylating drugs. So, but that was not the end of it. Subsequently, the concept came as minimal change disease is a podocytopathy, that is a disease of the podocyte. There is an alteration of the podocyte biology resulting from a complex interaction between the molecular signals and the soluble factors, as well as the metabolic milieu that is going to be there. The various genetic podocyte express genes which may be dysfunctional and resulting in the genetic nephrotic syndrome, or it could be the soluble factors, the circulating mediators, super, hemopexin. So many soluble factors have been implicated, which are coming up because of infection and cytokine mediated issues. Then there are the glomerular basement membrane itself may be actually affecting the podocyte by producing so many integrins and this laminin beta 2 abnormalities and so many molecular signals which may be affecting the podocyte. So at this end, we have to understand that podocyte is a really complicated cell that can be affected by the various signals which are coming from the T cells, B cells, the glomerular basement membrane, the plasma, the whatever soluble factors are there in the plasma, as well as the genetic factors which may be affecting this cell. So minimal change disease or idiopathic FSGS, that becomes a spectrum, and the trigger most often for the relapse or the first episode is infection or drug. And also, this is a spectrum. Why we are considering this as a spectrum with MCD on one side and FSGS at the end, and there could be a common mediator for the same. The severity of insult may be deciding which is the disease phenotype which is going to come. So what are the evidences to suggest that this could be a spectrum? So the trigger is the same in both the diseases. The resistant MCD, when you do a repeat biopsy, may reveal FSGS, and even biopsy documented FSGS sometimes will be steroid responsive and behave almost like minimal change disease. And both diseases of the podocyte may be associated with circulating permeability factors, and both, if resistant and you do a transplant, may recur. And if that kidney which is transplanted in this individual is taken out and placed in another individual who is not having nephrotic syndrome, they affected the proteinuria results. And so initial evaluation diagnosed as having MCD, probably after some time when you do the biopsy, is FSGS. So whether it is a progressive glomerular scarring which is happening because of proteinuria that is ongoing. So these are the various evidences to say that it could be the spectrum, and on one side is MCD and other is FSGS. So the current concepts on the pathogenesis of MCD, it could be a systemic disease where T cell and B cell dysfunction, the cytokines and other circulating factors are affecting the glomerular filtration barrier, producing a podocyte food process effacement and proteinuria. Or it could be the glomerular disease where podocyte is malfunctioning and there could be an angiopoietin 4 or CD80 overexpression. It could be autocrine or paracrine factors which are affecting the glomerular filtration barrier, and there is podocyte food process effacement and loss of GBM charge and all this in proteinuria. So all of us know that the viral infection or allergen is the initiating event most often, and it is the podocyte injury that is happening, and depending on the extent of the injury, the histology can be normal glomeruli at one end of the spectrum and FSGS may be at the other end of the spectrum. And the clinical outcome in the normal glomeruli, that is MCD, is remission, whereas the other end, FSGS, it could be steroid resistance. And same, the relapses can occur and you can have a steroid sensitive disease following subsequent relapses can become a steroid resistant disease as time passes. So whether the intensity of the podocyte injury is the factor that is behind this different behavior that is happening in primary or idiopathic nephrotic syndrome in children. So there is likelihood of remission and steroid sensitivity on the one hand, and depending on the very severe form of the injury to the podocyte resulting in the collapsing variant of FSGS, where there could be a point of no return and end-stage renal disease can occur following podocyte depletion. If the injury is too severe, podocyte depletion can occur, and then there may be a point of no return. So the pathogenesis becomes a complex immunologic mystery actually, and the signal one, we all know that the antigen is getting presented and the cytokines are coming up. We are having so many cytokines which are there, that is TGF beta, interleukin 12, 2, 4, 13, then TGF beta, all the interleukins and all the cytokines which are coming. And then antigen specific, the CD4 cells, the T cell subsets which are getting stimulated. which are actually Th1, Th2, Th17, and the T regulatory cell. T regulatory cell is having a master role in the nephrotic syndrome, nephrotic syndrome occurring as well as nephrotic syndrome remitting or not remitting. And the cytokine products will have its effect on the kidney. And finally, we will have an effaced podocyte food process, proteinuria, or even podocyte injury and podocyte loss. So the regulatory cells, the T regulatory cells, will have a huge role to play in this paradigm. And we can see that the T regulatory cells producing various cytokines will be having a negative impact on the macrophage infiltration and the injury to the kidney and the proteinuria, glomerular sclerosis and tubular injury. It is actually a check. Whereas if it is a skewed Th17 occurrence, we will have more inflammatory infiltrate, more renal damage. And so this regulatory T cells are actually in a complex network. It is complex immunological network that is actually acting as a check on the final outcome of whether the disease is going to be progressing and perpetuating, resulting in further damage to the kidney. So it is associated with nephrotic syndrome. More severe disease is associated with decreased activity of regulatory T cells, and elevated Th17 regulatory T ratio induce local tissue inflammation, renal injury, proteinuria, and progression of idiopathic nephrotic syndrome. That is finally the final point of no return that may happen. An immunopathogenic injury loop model is the next model that had been proposed in primary minimal change disease. In this model of dysregulation, if glomerular autoregulatory mechanisms or immunoregulatory mechanisms take place, the injury loop gets terminated, restoring the glomerular immune homeostasis. But if these autoregulatory mechanisms inside the glomeruli are failing, that could result in this resistant minimal change disease. So there is a T regulatory cell, T effector cell imbalance phase that is happening in this immunopathogenic model. So this model is having different phases that is occurring in the disease. That is the T cell dysfunction is this immunopathogenic injury loop model is actually getting triggered because of some infection or an allergen or the initiating event, whatever is happening. And so there is a phase of T regulatory cell, T effector cell imbalance phase. Then there is a podocyte injury phase. Then there is an injury loop phase. And finally, there is a restoration of homeostasis phase. And so there is a T regulatory cell dysfunction. At that point, there will be a lot of overproduction of cytokines, and there is aberrant expression of co-stimulatory molecules, which will perpetuate the injury loop and finally resulting in a lot of damage to the glomeruli. So this is the phase. You can see that this is the FOXP3 cells or T regulatory cell, which is at the center, the blue nuclei. And the T effector cells are the one with the red cells, which are there, with purple nuclei. And you can see that the T effector cells, once they are predominating, that is after an infection episode, the T effector cells will start producing cytokines. And these cytokines will be acting on the GBM as well as the filtration barrier, producing the imbalance, and the proteinuria is getting triggered because of the damage that is getting initiated. And this results in this will then lead to the injury phase, where we can see the food process effacement and podocyte retraction that is happening. We can see that there is an increased permeability to proteins, which are actually getting lost into the ultrafiltrate that is collected in the Bowman's capsule. And here also you can see that the T regulatory cell or the FOXP3 cell is actually not active. So this is the situation. Then the podocyte injury is happening. And then there is the injury loop phase where this is getting continued. There is an overwhelmed or dysfunctional T regulatory cell which is not able to check this cytokine production by the T effector cells. The T effector cells are dominating. And then there is a persistent CD80 overexpression and shedding that is happening. And in many of the studies, they have shown that the CD80 excretion in the urine is actually increased in the active phase of the nephrotic disease. And then this T regulatory cells, once they take over, they become dominant. then they will suppress the T effector cells, and then you can see that there is a reduced CD80 expression, the podocyte damage is reversed, and the proteinuria is actually under check. So this is the restoration of homeostasis phase that is happening. And then this another theory that is coming up is the the T cell CD4, CD8, what is the balance between the two that is happening. The depletion of CD4 cells and increase in the CD8 lymphocytes and macrophages in renal tissue will worsen the disease. So there is a protective role for this CD4 helper T cells, and more CD8 cells means more will be the disease as well as the steroid resistance that may come up. So this is the cytoskeletal alteration that can happen because of this T cell B cell interaction that is going to be there. You can see that the Th17, this Th1, Th2, the T cells are getting this, actually the B cell T cell interaction is happening, and this T cell B cell interaction which will affect the podocyte cytoskeleton, altering it and producing proteinuria. And so dysfunction in the regulatory T cell, again the regulatory cell T cell or TREG, the FOXP3 cells, which are the master moderator or modulator of immune response. And these cells, if they are not dominant, there will be an uncontrolled T cell activation and perpetuation of glomerular injury. So lymphocyte dysfunction that is happening in this manner with an imbalance that is there, that will result in lot of circulating factors that are there in the inside the plasma, as well as in the region of the podocyte, as well as the glomerular filtration barrier. And you can see that the Th17 imbalance which is there, which may be a factor which will be actually responsible for steroid resistance. And also this, actually the B cells came into the role of B cells, started attracting attention after this rituximab has shown to be effective in cytoskeleton stability as well as checking the disease. And then this Th17Q, as I have already told you, may cause steroid resistance. And cyclosporin A is a drug that selectively attenuates Th17. And that may be the reason why some of the steroid resistant disease may respond to cyclosporin. Then the CD80 is another molecule that needs attention, and CD80 induction is actually a physiological response to infection that happens in all of us. And CD80 expression will lead to an increase in the permeability of the glomerular filtration barrier so that the pathogen excretion can be facilitated. So definitely after any infection, we need to have the expression of CD80 on our podocytes, and there will be a nephrin, CD2AP and zona occludens. There can be sequestration resulting in a disruption of the sleep diaphragm complex that was found in mice models, and this helps in the removal of the pathogen that is already there in our body. But if this is perpetuated and the down regulation of CD80 B7 is not happening, then the proteinuria is also happening along with this infection induced problem, and that will continue and result in nephrotic syndrome. In steroid sensitive nephrotic syndrome, the disease is strongly positive for CD80 and negative for CTLA4. CTLA4 expression actually is lower. Once the CTLA4 expression is better, actually this disease will start responding to treatment in remission. Whereas in steroid resistant disease, the CTLA4, the CD80 overexpression, that is actually not seen in steroid resistant nephrotic syndrome, telling that that disease may be different and immunological involvement in that is actually may be different. And the CD80, there is a two-hit hypothesis that has come up. The first hit is the direct stimulation of the podocyte by viral infection, bacterial infection, allergen or T cell cytokine. And the second hit is an ineffective censoring of podocyte CD80 due to a T regulator cell dysfunction or impaired autoregulation of the podocyte. So the viral infection actually triggers, but the autoregulatory mechanisms in the podocyte, once it fails, that will result in an ongoing proteinuria which may or may not respond to the treatment. So this is the paradigm shift that has come from T cells to B cells and podocytes in the last decade or so after rituximab has come into play. And The MCD is resulting from an interaction between humoral factor and dysfunctional podocyte is one theory that has come up recently. There is an increased nitric oxide production by B cells in relapse, and the induction of remission by anti-CD20 monoclonal antibody, which is a surface protein on the B cell, and once it is antibody is there, there will be total B cell depletion. And podocytes may be involved in the expression of CD8 and this ANG4. Flow cytometry of the T helper cells subsets have actually found that there is no significant difference in the proportion of Th1 or Th2 ratios. So maybe T cells are not that important and B cells may be important, more important. And then there is this circulating permeability factor disease, or CFD, which is actually there for a long time with us. The super which has come up and then gone out of fashion because this anti-super molecules may not be found to be that effective. Then there are other circulating factors like angiopoietin, like factor 4, hemopexin, CD40 autoantibodies, cardiotrophin like cytokine factor. All this has been in studies and a lot of trials are there, and the therapeutic potential as an anti-proteinuric agent has been tried, but till now we are not successful in this section of complement this CFD or circulating factor disease. So after we have dealt with the pathophysiology of nephrotic syndrome in children, let us have a little bit discussion on the management of nephrotic syndrome. The guideline-based management is what is there with us to help us out with this intriguing disease. With the response is so varied. The management for the first episode and relapses, we all know. Then the difficult nephrotic syndrome of frequent relapse, steroid response dependence, and steroid resistance. These are the different aspects of management that we have to concentrate now. And the recent guidelines have come, the KDIGO 2012 we are having a long journey after that, and the last is the IPNA 2020 and the ISPN guidelines which came in 2021. And so the treatment of nephrotic syndrome as per the ISPN 2021 guideline, the therapy for the first episode, it is the same as we were telling for so many years together, that is the 6 weeks of 2 milligram per kilogram and followed by 1.5 milligram per kilogram given as a single morning dose on alternate day for 6 weeks and then discontinued. And the evidence is suggesting that continuing the treatment in this tapering doses over the next 2 to 4 months, actually it is not associated with a better outcome or fewer number of relapses as per the recent trial outcomes which are already there in literature. And therapy of relapse is the same as what we were teaching and practicing all these years. That is, we have to give 2 milligram per kilogram as a single dose or divided doses till the protein is trace or nil for 3 consecutive days, followed by 40 milligram per meter square or 1.5 milligram per kilogram on alternate days for the next 4 weeks, and then stop it. So stopping is actually for the disease that is the child is having an infrequent relapsing nephrotic syndrome, and all the definitions of that are very important, and the definitions are again in the guideline repeated. And but some difference that has come up is that this definition of steroid resistance. That definition has been changed by the IPNA guideline of 2020, where the lack of complete remission despite therapy with daily prednisolone at a dose of 2 milligram per kilogram daily for 6 weeks. In the previous ISPN guideline, it was 4 weeks and the KDIGO is 8 weeks. But the recent IPNA guideline as well as the ISPN guideline, we are now telling that we will be talking about steroid resistance or defining it at 6 weeks. At the end of 4 weeks, we will be actually telling that the child is not responding. So let us go to the next 2 weeks of confirmation period. And that after the confirmation period, at the end of 6 weeks, 2 weeks of confirmation, we will be making a definition of SRNS at 6 weeks. Then another definition that has come up is complicated relapse. That is a relapse that is associated with life-threatening complications like hypovolemia requiring IP care, severe infection like peritonitis, cellulitis, meningitis, then thrombosis. That is one definition that has been added this time. Then significant steroid toxicity, also the definition has come up. That is presence of hyperglycemia, then obesity, short stature, raised intraocular pressure, cataract, myopathy, osteonecrosis or psychosis as significant steroid toxicity. So a definition has come up for that. And another definition is the difficult to treat steroid sensitive disease, that is either the frequent relapse or significant steroid toxicity within frequent relapse, failure of more than 2 steroid sparing agents, like we have used levamisole, cyclophosphamide, mycophenolate mofetil. Of the 3 drugs, if we have used 2 and we have failed, then it is a difficult to treat nephrotic syndrome. So the ISPN guideline for frequently relapsing a steroid-dependent nephrotic syndrome is give prednisolone on alternate day and daily during infection. And frequent relapse steroid toxicity we are coming across, if the steroid threshold is more than 1 milligram per kilogram on alternate days, or more than 1 complicated relapse, the definition already is given, or significant steroid toxicity is there. If this is all no, then we can try levamisole or mycophenolate mofetil. And if this is S, we will be again going for mycophenolate mofetil or cyclophosphamide. And if these fail, then you have to think of cyclosporin or tacrolimus. And there is no need to do a renal biopsy if we are at till this level. And if we are using cyclosporin or tacrolimus, before starting CNI, a biopsy is indicated in steroid sensitive but dependent and difficult frequent relapser. And then the rituximab is one addition. All of us have used it, that it is a very effective molecule for steroid-dependent nephrotic syndrome. And then infections, as they are relapse triggers, a stress dose steroid during infection has been found to actually reduce the number of relapses during intercurrent infection. And so 7 days of short-term daily maintenance dosing, that is the same dose that was given on alternate day, or a stress dose steroid that is being given during intercurrent infection, will reduce the risk of relapse. And this is actually one of the guidelines that is there in this ISPN 2021. Then how will we predict frequent relapser or a steroid dependence? When we see a child first episode of nephrotic syndrome, how will we know that a child may go for frequent relapses or may become dependent? So there are certain factors which are important, that is onset below 3 years, clinical presentation of microhematuria, hypertension and AKI in the initial episode, and the treatment outcome in the first episode, that is if the time to remission is delayed for more than 20 days, the duration of first remission, that is the first relapse is occurring within 6 months of stopping steroid, that is the first remission duration is short, or occurrence of early relapse, 2 or more relapses in the first 6 months after initial treatment, that is associated with higher number of relapses or occurrence of steroid dependence. Then low birth weight also significantly increase the risk of a difficult nephrotic syndrome, and requirement of an add-on immunosuppression is also a factor that predicts future difficult disease. What is the outcome of steroid dependent or frequent relapsing nephrotic syndrome? If it is a low dose dependence, the childhood difficulties are there, but there is a light at the end of the tunnel, and so the child will outgrow the disease, and usually they are maintained on steroids alone. Whereas high dose steroid dependence and requirement of alkylating agents for CNI, the course is going to be difficult. There will be dyslipidemia, drug side effects, cataract, obesity, impaired growth, delayed puberty, and altered mental makeup of the child as the child is passing through adolescence, lot of problems with body image and all. And this disease, the relapse rate after 18 years is almost 30 to 40%, and late steroid resistance and risk of progression is another problem that can come up as the child is passing through the adolescent growth spurt. And the risk factors for adulthood disease are young age of onset, high number of childhood relapses, and use of CNI or alkylating agents. And now we have to deal with a little bit on steroid-resistant nephrotic syndrome, which is a real challenge, and the etiology is heterogeneous. But all of them, whatever be the etiology, whether it is genetic or immunologic, they all will have massive proteinuria, hyperfiltration injury, intractable edema, malnutrition, growth failure, dyslipidemia, hyperfiltration, then cardiovascular disease, atherosclerotic vascular disease, thrombosis, various severe infections because of the immunosuppression that they may be receiving in large amount of number of drugs as well as the dose of drugs, and the relentless decline in GFR that can come up as the child is passing through this disease. And the risk factors are older age of onset and renal impairment at the onset. So is histology important in SRNS? So it is shown that MCD 21% and FSGS 56%. So the FSGS histology, that is actually a pointer towards the outcome may not be that good as MCD. And 50% will progress to ESRD within 15 years, and there is recurrence risk after transplantation. So the IPNA guidelines which has come up again, we have touched upon that a little bit, that confirmation period for between 4 to 6 weeks. At that point of time, we will be starting the anti-proteinuric treatment with ACARB. Remember that starting ACARB is going to be a detrimental decision if the child is hypovolemic and there is a risk of acute kidney injury or hyperkalemia that is there. So a judicious starting of ACARB is important, and we will be continuing oral prednisolone plus or minus IV methylprednisolone can be used. At this point, a genetic or histopathologic diagnosis, both renal biopsy and genetic study is important. And if it is a genetic disease, we will be withdrawing all the immunosuppressants and continuing only ACE and ARB. Whereas non-genetic SRNS, we will be starting with this calcineurin inhibitors, which is the first line drug, which will be producing a good response in almost 40 to 60% of cases. Tacrolimus is considered to be a little better than cyclosporin in maintaining the remission and reducing the number of relapses. And we will be continuing it for 6 months. We wait, and if there is a response, we will have to just continue. In children with partial remission also, you will be continuing for almost 1 year and seeing, but there is no consensus as to in responders how long to continue the CNI and what is the trough level of CNI that is to be maintained, and that is no guideline is mentioning these things. As well as we have to do a protocol biopsy if we are continuing it beyond 2 to 3 years. A protocol biopsy is mandatory, and more than 5 years if you continue the CNI, there is always a risk of nephrotoxicity that may slowly come up with this tubulointerstitial damage that is there. And rituximab is actually revolutionizing the treatment of the frequent relapsing and steroid-dependent nephrotic syndrome. It is anti-CD20 monoclonal antibody, and the dose and all is this. All of us are using it. We are giving 2 doses or even more, 3 to 4 doses, 375 milligram per meter square per week to achieve CD19 levels to less than 1%. What is the optimum dose? There are a lot of studies that are coming up nowadays to see a low dose, medium dose, or high dose is going to be effective, and also whether a maintenance immunosuppression with corticosteroid, MMF, or CNI for more than 6 months is required, which will be producing a longer remission in those who are given rituximab. That also is under trials. And the side effects of this drug is infusion reaction, increased risk of infection. Persistent hypogammaglobulinemia is a problem, especially in small children. And the long-term side effects of restricted lung disease and progressive multifocal leukoencephalopathy also we have to keep in our mind. And the remission in RCTs have shown that the remission rate in SRNS is almost 40 to 46%, more with minimal change disease, that is around 60%, whereas in FSGS it is 40%. And steroid-resistant nephrotic syndrome, what is the natural history? The ESRD, that is ISKD, is telling that 5 years down the line, 40% will be in ESRD, and another study is telling 70% will be in ESRD. And malignant FSGS, that is the ESRD occurring within 3 years of onset of nephrotic syndrome, is found to be associated with more chance of recurrence following transplant. And following transplant also, the recurrence following transplant is another problem that can come up. The risk factors for recurrence is non-genetic SRNS, younger age of onset, rapid progression to ESRD and white race. 20 to 50% can recur, and 15 to 20% of those who recur will have a graft loss. And how to manage? The pre-transplant management is plasmapheresis, 6 sessions over 2 weeks till transplant, and at least a few will be given thereafter. Cyclosporin is supposed to be better drug for preventing this recurrence, and preemptive rituximab can be given to prevent recurrence as per the Prevent FSGS study. And post-transplant, again, plasmapheresis, CNI, and rituximab are supposed to be beneficial. And there are certain investigational treatments that are coming up and undergoing trials, phase 1 and phase 2 trials. The plasmapheresis, galactose and all, we are plasmapheresis, especially for those circulating factor, permeability factor disease. The galactose also for circulating permeability factor disease. Then zinc, ACTH analogs. But all these 3 molecules, how much it is effective is again under question. Monoclonal antibodies other than rituximab is actually coming up. Ofatumumab is a humanized anti-CD20 antibody, which is actually considered to be better than rituximab, especially rituximab being a chimeric monoclonal antibody is associated with development of anti-rituximab antibodies. So this is not having that problem, but infusion reactions are supposed to be more with this ofatumumab. Other molecules which are coming up are actually found to be failing in their effectiveness for nephrotic syndrome in children, and so may possibly go out of fashion. And this is another molecule that is endothelin type A receptor antagonist, which is now considered as a molecule which may replace the ACA and ARB, but research is going on. Then mesenchymal stem cell transplantation is another mode of treatment that is being tried in nephrotic syndrome. All this is telling us that this is a disease where people are actually hunting for more and more molecules which may actually optimize the treatment and actually help us to get out of this difficult issue. And there is a global anti-B cell strategy combining obinutuzumab and daratumumab in severe pediatric nephrotic syndrome. These drugs are actually given, first obinutuzumab will be given and then daratumumab. And these are actually second generation anti-CD20 monoclonal antibody is the first one. And the second one is targeting CD38. And the problem with rituximab, we all know that after a few months of treatment, the disease actually comes back because of the presence of memory cells as well as the plasma cells. So this double treatment is to targeting the memory B cells and naive cells, and daratumumab will be targeting the plasma cells. So this is actually these two molecules being given together, which is producing a lasting remission, whereas this is with rituximab, which will be actually sustained remission is not there. Here there is a sustained remission. So the more definitive treatments are in the pipeline, and so possibly we will have better outcome for these children in the future. So there is rapid advancement in the understanding of idiopathic nephrotic syndrome at the molecular, cell biology as well as genetic levels in recent years, and information gained is critical in stratification and recategorization. Insights into the pathophysiology will help us to better characterize the disease and develop targeted therapy. Circulating factor disease may be a single entity or a separate mechanistic disease needing targeted therapies which are different from the other group of disease. Recent guidelines have actually helped us in maintaining uniformity in management and assessing the outcome in studies. And novel therapies based on the common podocyte signaling pathways are on the horizon, and availability of large national patient registries actually accelerate the ability to trial these novel therapies. So we have to acknowledge the progress we made, but we have to understand that we still have a long way to go, that the things are better, but still not good enough. Thank you.
Thank you so much, ma'am, for the extensive coverage on nephrotic syndrome, both steroid resistant and steroid dependent. From scientific papers to the practical issues has been covered. Thank you so much, ma'am. Namal sir, you have anything to add on, sir?
No, wonderful presentation. Molecular pathology, the biology of the nephrotic syndrome of sex. She's taken us from pure definitions of from clinical definition, from symptomology definition, from response to steroid. She has classified nephrotic syndrome stratification according to the molecular basis of the disease and their response. I think it's an excellent presentation, ma'am. That's congratulated. And we're very grateful to Dr. Susan for presenting the interesting paper. Thank you.
Thank you, sir. And the next speaker is Dr. Anil Vasudevan. Dr. Anil Vasudevan is a professor, head of Department of Pediatric Nephrology from prestigious Institute St. John's Medical College Hospital. He is also taking care of the Molecular Medicine Department at St. John's Research Institute, Bangalore. And his area of interest is towards genetics of renal diseases, molecular basis of nephrotic syndrome, AKI, and low-cost devices. He is the current secretary of Indian Society of Pediatric Nephrology. He is also a member of Committee for Competence-Based Syllabus in Pediatric Nephrology, Medical Council of India. He is a member of PhD Committee, JIPMA, and he is also a member of Editorial Board of Asian Journal of Pediatric Nephrology. Over to Dr. Anil Vasudevan to give a talk on role of genetics in management of glomerular diseases. Over to Anil.
Thank you. Thank you, Namal sir and Dr. Kalaivani for your kind invite once again. So, am I loud and clear?
Yeah, you're clear, sir.
Thank you. So, okay, I'm just seeing whether this is my slide moving.
Yeah, your slide is moving. It is moving.
So good evening to all. Now we are going to discuss one important diagnostic tool that is increasingly being used in the clinical setting, especially in children with glomerular diseases. And with this wider use of this genetic testing as part of our diagnostic evaluation, we have the challenging task now to select most suitable genetic tests for each patient and then apply the results into appropriate clinical contexts. So what I'm going to do over the next 40 minutes, and before that, I would like to declare that I'm not a clinical geneticist or a basic scientist by training, so my knowledge of the technical aspects is not deep enough. And also, because I'm using various case studies, I'll be showing the reports, and these are only for educational purposes and not to promote any particular vendor. So over the next 40 minutes, I've divided this talk into two parts. One, where we are looking at the basics, because I thought that's important for the trainees, especially there are a lot of terminologies and testing methods that are available. And then the current way of reporting is a little complex, and that needs a little understanding of the basics. And then after that, I will be using illustrative case scenarios and some data to provide an overview of the genetics of glomerular diseases and how the genetic testing can help in management of these children. And since a lot of these testing methods are newer technologies, it comes with its own baggage, and we need to understand the limitations and the risks also. I'm not going to go into the specifics of these glomerular diseases because of time constraints. I will be giving you a broad principle of genetic testing. And before I begin, the literature, you have two terminologies that are used interchangeably. One is genetic testing, and another one is genomic testing. So, but I prefer the word genetic testing because genomics generally is the study of the organism's complete set of genetic information. So the concept of heredity is was known for a long time, ever since Gregor Mendel pointed it out and did a seminal work. But this concept of heredity was converted into a tractable problem in 1953 when Watson and Crick discovered what is called the secret of life, that is the structure of the DNA. But I must mention that there are a lot of other people who are not very well known, who are also should be given the credit. Like, for example, Frederick Meischer, who was actually the first one to identify that molecule as DNA. And second is Rosalind Franklin. As you can see, the picture that I've shown is an X-ray diffraction image of the DNA based on which Watson and Crick developed the model. And they went on, along with Maurice Wilkin, both went on to win the Nobel Prize in 1965. With the discovery of DNA, the genetic testing started coming into the clinical domain, but it was limited to very few diseases, and especially syndromic diseases and chromosomal abnormalities. The next big impetus for genetic testing came with the mapping of the human genome, which actually took 12 years and costed nearly $3 billion. And what we know now is that the human genome consists of 3 billion base pairs, which are roughly encodes for 20,000 genes. And these genomes, the genome is divided into the coding region consisting of the exons and introns, which roughly form only 5% of the entire human genome. So the rest of the 95% are intergenic regions, with 50% of them having repeat sequences. And clearly what it does, I'm sure it must be playing a major role in our body homeostasis and development. But what it clearly does is not very well known. And of the 20, it is assumed that the mutations or the variants that we look for in various diseases are mainly residing in the exonic regions of the gene. Of the 20,000 genes, until now, roughly 4,100 genes have been mapped to various diseases. So, so this discovery of these of the DNA and understanding the variations gave rise to the central dogma theory, wherein the genetic defect leads to an abnormal protein, and then which leads to a disease. And there are many types of variants that can cause this pathogenesis of the disease. It could be a change in the sequence of the DNA. it could be changed in the amount. That is, the genes could be deleted or duplicated. So instead of 1, you have 3 or 4 genes or sequences. There could be a change in position, mainly like, for example, translocation in chromosomes, which leads to various syndromic and malignancies, and also change in numbers, like, for example, trisomies. So, but in clinical practice, especially in renal diseases, we are interested in only 2 types of variants. Most chiefly, it is the small variants. So as you can see, a 1 base pair change, what is the single nucleotide change, can lead among the 3 billion base pair, can lead to a disease. And in addition to that, there can be insertion and deletions, which typically are large, like from 2 to 1,000 bases. So these are the common variants that we look for, either using Sanger sequencing or a next generation sequencing. Increasingly, in the last few years, another type of variant is coming in the testing domain, and that is copy number variations. Now, the differentiation between small insertion deletions and copy number variants is specifically on the basis of the length of the affected DNA. As you can see here, copy number variation affects from 1,000 bases to 100,000 bases. So these are really large deletions and duplications that are responsible for the diseases. So these are the broadly two common type of variants that we look for when we order a genetic testing. So these variants, when we look in detail, are further divided based on the change. As we all know, the nucleotides, 3 nucleotides code for a particular amino acids, and a chain of amino acid forms the protein. So based on how this nucleotide change of the change of nucleotide, that is the A, C, U, G, and G change affects the amino acid, based on that, we can categorize these variants. So for example, as you can see, the first one is a normal variant. So it has, I don't know why it's not highlighting. And then, as you can see, a change in 1 letter, as I've seen, the letter A, in one of the nucleotide codon, it's called a 3-letter nucleotide is called a codon, it has not resulted in the change of the protein. As you can see, it is still proline, and this because of the redundancy of the amino acid code. However, when there is a change in one of the first amino acid in the second codon, that is letter T, which is highlighted in red, the amino acid changes to serine. And this is known as missense or a non-synonymous variant, while when the amino acid is not changed, even though there's a change in the nucleotide, it is called a silent or a synonymous variant. Similarly, when there's an insertion of an extra nucleotide, like in this example, T has been inserted between A and G, it results in the shift of the coding sequence. For example, the T is replacing G, and the G is pushed into the next codon for the coding. So there's a shift of the amino acid sequence, and as you can see here, it completely changes the amino acid sequence, and this is called as a frame shift mutations. And if the insertion is like a insertion of 3 nucleotides, it changes the amino acid, but it does not change the frame. As you can see here, the amino acid still starts with the glycine amino acid. It does not change the frame, and these are called non-frame shift mutations. And there are changes in the nucleotide that results in the cessation of the formation of amino acids, and these are called as stop mutations. So to pick up these variants, there has been evolution of the sequencing tools. After the discovery of the DNA, the major method that was used was the Sanger sequencing, developed in the 70s for a very long time, and also some of the PCR-based technologies like restricted fragment like polymorphisms. And then came the Big Bang after the mapping of the human genome, and that's called the next generation sequencing, where these machines could sequence a large amount of the genome simultaneously. And over the years, these machines have just changed, not in the terms of capacity, to do this sequencing. For example, this NovaSeq has a terabyte in capacity, so they can run hundreds of samples, and also the speed is very high. So you can now have a genome sequencing that is available to you within 48 hours. And also there is a change like in other technology, like what is called a nanopore technology, where you don't have to amplify the genomic region. So it is helping us reduce one step in this complicated process of sequencing. So in summary, you can categorize the genetic testing methods into the first generation, which is Sanger sequencing. Then comes the second generation, which is the next generation sequencing. It does not denote a single technique. Rather, it refers to a diverse collection of high throughput post-Sanger sequencing technology. Just to give you a scale of high throughput, you require 100 Sanger sequences to run round the clock for 3.5 years to sequence the human genome. And these second generation machines can do it in 48 hours. So that's a scale up that is seen with these second generation machines. And after that, you have what is called the third generation machines, which are single molecule sequencing like the nanopore technology, where you don't use an amplification step. And apart from that, to pick up these large deletions and duplications, you have other testing methods, what is called the MLPA and chromosomal microarray. And I'll come to these when you should be using these testing methods and in which patients. So when you look at Sanger sequencing, it briefly, you have to select the gene which you want to sequence. So you amplify that particular region by using a PCR, and then you sequence using a sequencer. And these are the color codes, nucleotide that comes out, and you read that. And this is considered as the gold standard for identifying a single nucleotide variant or a small insertion deletions. Compared to that, workflow of NGS is much more complex. I'm not going into the details, but just to inform that there are two parts. One is the wet lab, where you process the samples, you make libraries, you amplify the segments of regions of interest, and then perform the sequencing. And because you're doing a large number of genes and you're doing many patients simultaneously, a large amount of data is generated, and then starts a second process that's called the dry lab, where it goes through, where it is converted into a readable format through various steps and various files. And then that sequence is interpreted using various bioinformatic tools. So in NGS, now this bioinformatic is considered one of the critical and the crucial step in annotating the variant and also in interpretation of the variant. So since NGS-based testing is most commonly used, I'm just comparing these sequencing methods. So you have the targeted panel where you're sequencing only a few hundred genes. Then you have the exome sequencing where you're sequencing the entire coding of the coding region, that is all the 20,000, or only those genes that are mapped to the human disease. That's around 4,000 genes. And then comes the genomic sequence, which we don't use in a clinical setting, where you are sequencing both the coding, non-coding, and the heterogenic and the other regions. So the advantage of targeted panel is that it has a higher depth of coverage compared to the exome and genome sequencing. It can detect these small variants, but it is difficult to detect the large variants with a targeted panel. Whereas in genomic sequencing, you can detect large deletions and duplications such as copy number variants. One of the advantages of a targeted panel is that you're limiting your incidental finding. So because you're sequencing a large number of genes in an exome and a genome sequencing, the probability of having an incidental finding is much higher as compared to the targeted panel. I'll be coming to these details of these when I'm discussing how to choose a particular test. So now, how do you know this, whether the disease variant is disease causing? In 2015, the molecular genetic group and Association of Molecular Pathologists came up with a framework to interpret the variants that are identified. And they're built into 5 categories: pathogenic, likely pathogenic, uncertain, significant, likely benign, and benign. And from a clinical perspective, it is the pathogenic and the likely pathogenic, as a general rule, the clinician should act on. And these category of variants are generally very rare in population. So you generally call a pathogenic variant. As you can see, the probability of it affecting function is close to 99%. It has either been reported in other patients of similar phenotype or has been shown to be very deleterious. The likely pathogenic, on the other hand, the probability is more than 90%, but much less than what you call as a pathogenic. And these are usually not previously reported. They're usually novel, but known to be deleterious, like a Stoke codon, which creates a truncated protein, although not reported in other patients, can still be considered as a likely pathogenic. The other group which could be potentially considered is the variant of unknown significance, which could either be causal to the disease or maybe benign. So as you can see, the probability is very large, from 5% to close to 95% the probability of this causing the disease. Hence, these variants require additional follow-up studies and functional studies to assess its significance and reclassify. And obviously, the benign and likely benign, we do not generally react to this variant or act on this variant. So to interpret this, there is a complex criteria that has been developed by the ACMG, and the rules. And for this, basically, you require the databases of these variants identified. You also require the healthy reference databases to know the allele frequency. Then there are computational prediction tools that tell you whether this variant is going to create a dysfunctional protein or not. And also look at how this sequence is conserved across species. The more it is likely conserved, more likely that the particular sequence is playing an important basic function in the organism. And then you add up the functional evidence, either using animal models or in vitro assays, to know whether this variant that you have identified is harmful or not. This basically is done through data mining, and you use all this information to know whether the variant is pathogenic or likely pathogenic or otherwise, or VOS. And this is an example of a conservation. As you can see, this variant that has been identified in COL4A3 is the sequence is very similar right from human to a unicellular organisms, as you can see. So it's probably playing a very important role in the function, and any change in the nucleotide in this region probably can be disease causing. And why is this important to know? Because a lot of this information is put up in the genetic report, which I'll come to next. So when you're reporting this variant in the genetic report, it has a particular format. It's like finding a person living in one part of the world. In order to track that person, you need to know which country the person is living, the city, the street, and the house number. Similarly, when you identify a variant, you want to know, of course, we are dealing with human genome, so it's a human genome. You want to know where in which chromosome it's located, and in the chromosome, in which gene is this variant identified, and whether this variant is identified in like complementary DNA or in a protein or in a mRNA, and what is the nature of variant. So these are the information that goes into the report. So this is the way they undertake the report. As you can see, the P, C, G, and all that stands for the protein coding region and the genomic region. And as I explained to you, there are various different types of variants. One is single nucleotide substitution, which is with a greater sign. Then you have deletions, which is written as del, duplications, which is written as DUP, insertions as add. So there are various ways, standard ways of reporting this, the variants that you have identified. So how do you interpret an NGS report? So as you can see, it is presented in a tabular format. So first is the gene in which the variant is identified. You have a particular transcript number, because when you're comparing it to a reference sequence, it is important to know to which transcript you have compared it to, as there are many transcripts that are available. Then comes in which in the gene in which exon it is located. Then you will, and then the type of variant that is in the coding. So as you can see, it's written C here. So it's in the coding DNA sequence. You will know the position and what is the change in nucleotide. So the greater sign is replacement. So the C is replaced by T. And what is its effects on the amino acid is also mentioned here. The P stands for protein. As you can see, the alanine is changed into value. Then after that, and you can see here, these are the various descriptions. So the C refers to the coding DNA. So if it was P, it's the protein sequence. So after that is the zygosity, whether this variant is identified in one allele or both the alleles, and then to which disease it matches in the online Mendelian website tool. And then you combine the zygosity information with the inheritance pattern to understand the nature of transmission. And finally, what the classification of this variant is given, whether it's pathogenic or likely pathogenic. And then this tabular format is now converted into a sentence, which comes something like this, where it tells you whether about the type of variant, where it is located, in which gene is it located, and so on. I will come to the depth later on, but so then it gives a variant detailed description. Here where I feel that we should have some basic information, and this is based on the elements of categorization that was seen that I had shown you a little later. So as you can see, this variant is reported in a major intrinsic domain that plays an important function in the protein, and this variant is not seen in the healthy data set, either in the 1000 genome or in the Genome AD database, which means that this is a very rare variant. And then the computational tools like the SIFT and and LRT and mutation taster has shown that this variant can produce a dysfunctional protein. So, and finally, this sequence is conserved across species. All this information is very useful, especially when the classification of the variant is a variant of unknown significance. Using this information, you can fairly judge whether the variant of unknown significance is likely to tilt towards a pathogenic or a benign side. So it will give, these are the information that gives the details on basis on which they have classified the variant. So, an important technical is that when you ask for a genetic testing, it's very important to know the genes which you are interested in are covered. So that is also given in an annexure. As you can see here, the genes in this particular testing are covered 100%. And also another factor that needs to be seen is the depth. That is how many times the particular sequence has been read. So for example, on the extreme side, the sequence has been read 4 or 5 times, while in the center, the same sequence has been read more than 10 times. And for a variant to be technically correct, the depth has to be somewhere between 20 times to 30 times. That is, the sequence has to be read 20 to 30 times. And this is also mentioned in the report. So with this basic, I'll now come to the core topic of the genetics of the glomerular disease. The glomerular disease, as you all know, comprises of a heterogeneous group of diseases. There are no consensus on the classification of the genetic causes. In fact, many of the glomerular diseases like nephrotic syndrome or a lupus can have both monogenic and acquired causes. Some like Alport have only genetic etiology, and some like post-infectious glomerular nephritis has only an acquired cause. So, with a genetic tendency, it's not a definitive mutation that has been identified. So as you can see, the glomerular disease is pretty heterogeneous. So one way of looking at the genetics of glomerular disease is to categorize by cellular location. So as you know, the glomerular filtration barrier consists of podocyte, endothelial cells, and the basement membrane. So based on that, you can categorize them. For example, in the podocyte, you can further categorize by this location of the protein coded by the particular gene, whether it's mitochondrial, whether it's cytoskeleton, whether it's in the nucleus, which is highlighted. The red, what is highlighted is the podocyte. Similarly, the endothelial cells, which is highlighted, the injury, which is typically seen in HUS, can be caused by around 8 to 9 genetic, it has 8 to 9 genetic causes. So this is a way of categorizing this based on the cellular localization. And as you can see on the right side, the graph, that the number of genes that are being discovered is amazing at a very rapid pace. So whatever genes that I'm now quoting may become redundant after a year, the addition of newer genes or elimination of the known genes. In addition, there are other diseases that we don't typically see in children, that is like Fabry's disease, which is a very rare disease, then what is called a fibronectin glomerular nephropathy, and also monogenic lupus. So my focus is mostly going to be on the genetic aspects of the glomerular filtration barrier. I'll skip this. As I said, the clinical complexity of the glomerular disease is because we have been there is a lot of overlap in the symptomatology of proteinuria and hematuria, and also we have been using traditionally the syndromic combination of the clinical and histological features for the nomenclature of the glomerular disease. Like based on whether it's a nephrotic or a nephritic or rapidly progressive. And added to that is that many of these glomerular disease can have extrarenal features, like in Alport, the eye and the ear. It can have many syndromic features, like in steroid-resistant nephrotic syndrome. You can have microcephaly, you can have eye changes, you can have genital abnormalities, and so on. So coupled to this clinical complexity is the genetic complexity. where many genes can cause a single disorder like steroid-resistant nephrotic or HUS. You can have one gene and unrelated disorders. You can have the gene which causes both autosomal recessive and an autosomal dominant pattern of inheritance, like WT1, Wilms tumor gene. And then you can have many a spectrum of phenotype with one gene, like in NPH2 podocin mutation can cause nephrotic, steroid-resistant nephrotic syndrome. It can present as only idiopathic proteinuria, or the child can present it just end-stage renal disease. So to understand this, that who are more likely to be having a genetic etiology, what has been observed is that those who are having a younger age of onset, who have a family history of the similar kidney disease, and also the kidney subtype, whether it's a SRNS or Alport, they are more likely to have a genetic etiology as compared to someone like a child with lupus nephritis. And also the presence of extrarenal features suggests that they're more likely to have a genetic diagnosis. And roughly 1/3 of the steroid-resistant, about 80% of the Alports, nearly 1/3 of HUS and C3G have a genetic etiology identified so far. How does genetic testing help? It helps in many ways. Especially, it negates the need for a prolonged diagnostic investigations and surveillance. Because as I said, there's a lot of phenotypic overlap in terms of symptomology and histological features. So this confirming or clarifying this genetic diagnosis has demonstrated the clinical utility in a variety of situations, which I'll come to it. And, and confirming a suspected genetic diagnosis excludes a lot of other differential diagnosis. So for example, when you have a child with an atypical nephrotic, you don't know whether it's Alport's or it's an unusual form of an HUS. So genetic helps in this. Apart from that, it helps in treatment decisions, either withdrawal of immunosuppression or introducing specific interventions. It helps, it provides prognostic information, including informing targeted surveillance of extrarenal manifestation. I will highlight a few case scenarios in that. It helps in transplant planning, especially in recurrence risk and living donor ascertainment. It offers the potential for antenatal diagnosis if the parents are interested in having another child. Apart from these direct clinical benefits, it also helps in understanding the pathobiology of the disease process and also stratification of these group of patients in clinical trials. And I will go using illustrative case scenarios to highlight each of these. Before I come to that, one of the big impact has been in the diagnostic, the utility of genetic testing. As you can see here, especially in those who do not have a clear phenotype. As you can see here, this is a study in which they have done, I'm focusing only on the glomerular part, done exome sequencing in 98 patients who had Alport, clinical diagnosis of Alport syndrome or a nephrotic syndrome or NYH9. And among these glomerular diseases, the diagnosis was confirmed in a significant proportion. But what is of interest is that the diagnosis changed in 5%. And also new diagnosis was identified who were presumed to be nephrotic, who turned out to be a PAX2 mutation. So of CACUT. So it's not only helped in reclassification, but also in identifying a new diagnosis. So how do you proceed with genetic testing if you have a child with glomerular disease? Now that I've told that who are more likely to have a genetic etiology, first is to identify patient at risk and then do a detailed pre-test counseling. I'm not going into the details because of a lack of time. Then obtain informed consent, and then you select and offer the test, and then you inform the result that you have got, and then provide the post-test counseling and follow-up. A lot of these now a physician has to do because physicians are the ones who are ordering these genetic tests, and the reports usually come back to them. So identifying patient at risk is very important. For example, I was asked to opine on this child where this child was of nephrotic syndrome, renal biopsy suggestive of minimal change disease, and was steroid dependent. And the child underwent a genetic testing and identified a COL4A mutation, which was heterozygous of uncertain significance. Now the query was, what do I do? So my question was obvious. Why did you order a genetic test in this patient? So we need to have a very clear understanding of who are more likely to be benefited from a genetic testing. So, in example, in nephrotic syndrome, the genetic testing is recommended in congenital nephrotic, initial resistance during infancy, nephrotic syndrome with extrarenal features, familial steroid resistance, and if there is no response to therapy with CNI. In Alport syndrome, traditionally, anyone with recurrent episodes of family history of hematuria or young onset renal failure with deafness or ophthalmic manifestations or proteinuria, or on biopsy was having a thin glomerular basement membrane or a typical changes of basement membrane considered. But more recently, they have expanded the criteria, and this was published just last month, wherein any patient, apart from these phenotype, anyone with only persistent proteinuria without hematuria, steroid-resistant nephrotic syndrome, FSGS on biopsy, and a newer criteria, that is the familial IgA nephropathy. And anyone with an end-stage renal disease of unknown cause, they are recommending testing for Alport syndrome. In HUS, it is practically all children with atypical HUS need to undergo genetic testing. Similarly, children with C3 glomulopathy, which is related to HUS. However, in other diseases like lupus, it's not very clear, but generally a monogenic form is found in those children who have lupus, whose onset is less than 5 years of age and who have a very severe course and with refractory to all forms of treatment. So apart from these phenotypic glomerular diseases, there's another group where you should consider glomerular disease, and that is a kidney disease of unknown etiology. Typically, these patients present an end-stage renal disease with a normal-sized or a slightly smaller-sized echogenic kidney. As you can see, this is a combination of various studies done in children and adults in chronic kidney disease and end-stage renal disease. And you can see here, the Mendelian etiology approximately accounts for varies between 10 to 40%, depending on which group of patients you have seen. The higher range is usually seen in children. And what you can see from this cartoon is that the genetic diagnosis is largely driven by glomerulopathy, as you can see here. It is largely driven by glomerulopathy and most commonly by the type 4 collagen gene, as you can see in this picture. So it's an important group of patients in whom you should order genetic testing to uncover an underlying glomerular disease. And as I just said, in Alports, they have identified in children with familial IgA the Alport variant. So any child with an IgA with a severe course, they have recommended, and which is familial, they have recommended to screen for Alport genes associated with Alport syndrome. Now, coming to a complex or a difficult thing, what test do you order? So as you can see, I've listed out an array of tests, and each of these genetic testing methods have its merits and drawbacks in the current landscape of clinical testing. And it is mainly guided by the clinical presentation of the patient and the number of potential genes associated with the suspected glomerular disease. Now, my approach is to eliminate. So which is a test I do not require. So clearly whole genome is research-based, so I will never order that. Similarly, Sanger sequencing is restricted to if you have one gene disease, or a few genes like an hyperoxaluria, but that is rare in glomerular disease. Or if you want to confirm an NGS variant, or if you have a familial disease with a known variant, where the index child or the other sibling has a mutation, for example, in NPHS2, then in the other child who has developed nephrotic syndrome, you just have to screen for NPHS2. And also, many of the genes are not covered well in NGS. And if you think that that particular region of the gene, a lot of variants have been reported, then you need to cover that using a Sanger sequencing. So Sanger sequencing has its own role. So that leaves us with two options, either NGS panel or the Mendelium clinical exome testing method. Apart from that, as I said, these identify small insertion deletions and single nucleotide variants. If you want to detect large deletions or rearrangements, like in HUS, it is very important, apart from, in addition to NGS, you also order MLPA. Similarly, if a disease is associated with COMP number variations, it is important to either order a SNP array or a comparative genomic hybridization testing method. So based on the clinical situation, you have to combine these MLPA array with the NGS-based testing. So this is an example where when we did a work using Sanger sequencing, you do one gene by one gene, it takes a lot of time, the yield is very low. But the moment we shifted to a targeted gene panel that included 17 genes associated with steroid-resistant nephrotic syndrome, the hit rate from 5% went to 20%. So that's the yield, and that's an advantage that you get when you use a NGS-based genetic testing method. So this is a good example to answer. So clearly, NGS-based testing is the way, but what do you choose, panel or a clinical exome or a whole exome? So this is a study in which a panel-based testing was done in 3 glomerular conditions, HUS, NS, and ALPOT. And as you can see here, a set number of genes were looked at, and in the left side, you can see the yield. So 6% of HUS, 14% and 30% of ALPOT had an identified variant. Now, the group, what they did retrospectively was subject these same patients who are undergone panel testing with an exome-based testing. That is the clinical exome testing. And when they did that, I mean, it's a busy slide, but what they identified was 12 patients who were initially diagnosed as HUS and only tested for HUS had some other form of disease. Some of them had cystic disease, Bartle-Biddle, and some of them had, of a neonatal onset of HUS. So as you can see here, the diagnosis totally changed in these patients. In addition, what they also found that many of the variants like PAX2 UMOM, which was not missed when you order a targeted panel of HUS, nephrotic, or ALPOT, which is usually missed, is of autosomal dominant inheritance. Not only is it important, so this is important from a diagnostic perspective, but it's also important from a family screening perspective. So this is a good example of how an exome sequencing can be more useful as compared to panel sequencing. So, but what do you do practically? So nowadays, when you order a panel sequencing, actually these targeted gene sets are built on an exome backbone. That is, they do a clinical exome, but report only on those targeted genes. So it is good that if you mention all the clinical details and the clinical diagnosis, so the initial set of genes to be analyzed can be prioritized. Okay, and then when you don't find a variant, you can look at additionally clinical relevant genes using an exome sequencing, which you cannot do when you order a panel. And also the cost difference between a panel and exome is narrowing. So there's hardly 2,000 or 2,000, 3,000 rupees difference. So you're going to get a much higher yield at a much lesser cost. Of course, sequencing more number of genes means the probability of finding an incidental finding is higher. So you have to balance this. You have to counsel the patient family about all the risks and benefit of going with an exome sequencing compared to a panel. When I say exome, I'm usually referring to the clinical exome. Clinical exome refers to those genes which have been mapped to known human disease. So that's around 4,000 to 4,000 genes. The whole exome refers to all the 20,000 set of genes that needs to be sequenced. But in a clinical practice, we generally go for a clinical exome sequencing. So how is it useful? So this is an example of a boy, 10-year-old, who presented with mild periorbital puffiness. Clinical examination was unremarkable. The family history of an older age onset of ESRD. As you can see from the labs, they had nephrotic range proteinuria, but the serum albumin was normal. Because of this atypical feature, they were subjected to a biopsy, which showed 5 glomeruli, and surprisingly, there was minimal effacement in spite of proteinuria, which suggested that it is not a porous cytopathy, and also neither a basement membrane disease because the GBM was normal. So, and because there's a discrepancy between the urine albumin and the spot protein creatinine ratio, we thought it's maybe a phenocopy. What is a phenocopy? Ideally, phenocopy meant an acquired disease which mimics a genetic form of a disease. But now the terminology is being expanded. Phenocopy refers to diseases that are caused by a different set of genes and causes and involves a different pathophysiological mechanism. So here, what we found was a gene that is codes for this for the CLCN, and the variant and the abnormality in the gene causes dense disease. So, so this is how genetic testing helped. And suppose I had have asked for only targeted panel of nephrotic syndrome, I would have missed this diagnosis. Because I had a doubt that it may not be a typical steroid-resistant nephrotic or a podocytopathy, I asked for a clinical exome sequencing. And then when we went back and checked the urine microglobulin, it was very high. The calcium was borderline high, and also tiny specks of calcification were seen, suggesting that it is indeed a DEN phenotype presenting as a nephrotic syndrome. So a lot of phenocopies like this are being identified, mainly like an Alport, Fabry disease, PAX2 renal coloboma syndrome, and medullary cystic disease. And importance of this is not only in reclassifying your diagnosis, your clinical diagnosis, but also many of these conditions can have extra-renal features. So you need to look into these. So suppose you have a nail patella syndrome, they may have glaucoma. So it's important to subject them to ophthalmological evaluation. Similarly, if you have Fabry's disease, of course, you need to do the immunological and the cardiac checkup, and so on. So apart from the diagnosis, looking at additional clinical features and monitoring becomes important. So this is a 3-year-old female child who presented with nephrotic syndrome, hypertension, and with a high creatinine at the time of diagnosis itself. There are no extrarenal manifestations. Biopsy referred FSGS. Because of this presentation in CKD, of which what looked like a nephrotic with FSGS, we subjected to genetic testing, and this is what it showed. It showed a mutation in WT1, and the variant is in a heterozygous state is associated with Fraser syndrome. Now, in Fraser syndrome, it is not just the kidney, but also it causes pseudohermaphroditism and an abnormal karyotype. So hence, it is important in this child that we do a karyotype. We also did an ultrasound of abdomen, and not just the kidneys, to look at, and indeed what we found was streak gonads on laparoscopy at the time of insertion of CAPD catheter. So you can see here how a genetic testing resulted in change in management. And this is something we have to remember while counseling itself. Because if you don't counsel that of these, especially nephrotic child, in an adolescent or a young female, the parents may get a little shocked. You know, we are talking about kidney disease, and now we are talking about something more than the involving of the kidney. Apart from the diagnostic, genetic testing in glomerular disease has various therapeutic implications. We know that those who have a genetic cause in SRNS do not respond to immunosuppressions. In addition, a lot of genes associated with SRNS can respond to targeted therapy, like coenzyme Q10 supplement in CoQ pathway, eprinolone in ARG mutations. In addition, in Alports, you optimize the antiproteinotic medication because that is found to retard the progression of renal disease. Now, this is an example of a baby, who was around 1 year old, presented with nephrotic features, but also had thrombocytopenia and anemia. So because of these unusual features, we did a genetic testing, which turned out to be a DGKE mutation. So what is its importance? It not only helped in identifying what is the exact diagnosis, but we also know that these children do not respond to eculizumab if it was available, or to plasmapheresis. So conservative management and invariably these children progress.
Hearing you. Then I realized that I'm out.
Not only diagnosis, but also in deciding what kind of a treatment to be given also was helpful in this case. And these genetic testing also helps in prognostication, like example, typically in nephrotic syndrome, if you find a pathogenic mutation in any of the genes associated with nephrotic syndrome, we know that their ESRD-free survival is very poor. In fact, only 1/4 of them have a 10-year ESRD. So then 75% of these children with a genetic diagnosis, as highlighted in the blue color, go into ESRD within 10 years of diagnosis. Similarly, in Alport, it is not only the genetic variant, that is the gene in which it is identified. I'm sorry, Arman, I don't know why it's moving the other way. Yeah. So in Alports, it is not only the type of variant, but the gene that is involved also can help you prognosticate. For example, the most severe form is seen with an X-linked COL4A5 as compared to variants seen in COL4A3, A4, A3 or A4. And also these patients tend to have ESRD at a much younger age. Similarly, even the type of variant in these genes also you can fairly guess the course that they're going to have. For example, those who are having a nonsense or a truncating mutations do much worse as compared to those who have a missense. Missense means a single nucleotide substitution that changes the amino acid. So as you can see here, the line in blue in the graph shows truncating mutations, and the line in red shows the missense. And you can see that these patients progress much faster to ESRD as compared to the other type of variant. So these are the ways in which genetic testing helps us. Similarly, in HUS, as you know, that the genetic forms are associated with severe morbidity and mortality. As you can see here, if you have a mutation in CFH or a CFI, the risk of ESRD in the first year itself is much higher as compared to someone who had a mutation in the MCP gene. As you can see, hardly anyone progresses into immediate ESRD. And also, the risk of death or ESRD on the long term also can be prognosticated based on the type of variant that the variant in which gene you have identified. And apart from these clinical utility, it also helps extends beyond the patient. So for example, this is a 7-year-old girl born out of non-consanguineous marriage, diagnosed as SRNS with hypertension. Parents denied any family history of nephrotic syndrome or ESRD in the family. Renal biopsy showed FSGS NOS. EM was not done because of cost issues, and this child was also tacrolimus resistance. When we did genetic testing, we identified a COL4A5, the gene that is involved in Alport syndrome, which is classified as VUS. Now, when we went back to the family, the mother came up. We screened the mother, the parents, and it was found that the mother had proteinuria and also microscopic hematuria. And then she revealed the history that she did have history of gross hematuria in the past, which is treated as UTI. So you can see the value here that just by genetic testing not only helped identify the specific etiology in the child, and it's the prognosis and what you need to do with the treatment, but also helps in identifying additional family member who can be affected with the renal disease. The genetic also plays a very important role in transplantation, especially in HUS, Alport, and in nephrotic steroid-resistant nephrotic syndrome in different ways. So this is a child who was 15-year-old diagnosed with steroid-resistant nephrotic syndrome, ESRD at 11 years of age, and was considered for renal transplantation with mother as a donor. And this is what it revealed, the genetic testing. It was a mutation in TRPC6. Now, if you can see the inheritance pattern, it is an autosomal dominant. Now, the information that we get is that the recurrence in this child is going to be negligible because it is a genetic etiology. The second is from a donor perspective. Because of its autosomal dominant inheritance, it is important while choosing the donor, especially the mother, to be screened for that variant. So this mother, who was 38-year-old, was screened for the variant and did not have this variant, and hence was cleared to be the donor for the child. Now let's take this child who was 17-year-old when the child was considered for transplant, who had SRNS at the age of 7 years, CKD at the onset of 13 years of age. The initial biopsy was showing FSGS, and the second biopsy, because of after the genetic testing, we wanted to confirm it was Alport. And this child was considered with mother as the donor. So based on this report, which showed COL4A4 mutation, although it was an autosomal recessive, but still it was important to screen the parents. Okay, and here the mother was found to be a carrier of the same variant. Now this is a recessive disease, a recessive pattern. But still, why did we exclude this mother as a donor? Because it's well known that heterozygous variant carriers of 4A3 and 4A4 can manifest. It is not that it is totally benign, can manifest ESRD in a small proportion. So, hence, the grandmother came forward who was screened and did not show a variant and was identified as the eligible donor. And both this case came as a counsel to me from my a very good colleague from Calicut. So now, what do you do when you know that this child with the glomerular disease is likely to have a genetic cause, and you're very confident? The biopsy also, like in this child, has shown Alport features like the basement membrane, typical features, basket weaving, and segmental changes. But when you did a NGS-based testing, you found that the Alport gene, there are no variants that are identified. So first think of a technical, but here you can see the 100% discovered the gene. So what do you do next? So possibility is technical, that coverage may have been low, or the depth of staining, but generally that is known because there's a clear phenotype of Alport in this consider. But in those who do not have a clear phenotype, you need to reconsider your diagnosis. Was it really a steroid-resistant podocytopathy, or was it really a HUS? Or it could be that there are other type of variant that can be missed by NGS. Okay, so what can NGS miss? It can miss variant in the intronic regions. It can miss large deletions. Although now they have better bioinformatics that can identify copper number variation, but it can be missed. And especially when you're doing clinical exome, because of technical, because of filtering, that variant could have been missed. Or it could be a true genetic, but with a variant in a yet to be discovered gene. So what it tells us is that NGS testing is not a static test. It's a dynamic. That is, you can, just having a ruling out a genetic variant does not mean the child does not have genetic disease. So these patients need to be followed up. The genetic evaluation may need to be redone once newer genes are identified. So, for example, in Alport, what has been shown is that in the Japanese group is that those who do not have variant identified on NGS, when they did an MLPA, that is looking for large deletions, they identified an additional 5% of the patients with Alport. So it may be possible in the patient whom I have described, that was a large deletion which was missed by NGS, and we need to order an MLPA to know whether a large deletion was missed. So this is how you combine various tests in the diagnosis and management of glomerular diseases. There are many challenges. I'm not coming into it. These are the last two slides. One is the technical challenge, especially when we are doing exome sequencing. A large data is generated. Now we have to find out one variant that is going to cause the disease. So a lot of bioinformatic improvisation has happened over the years that has made it more robust, but still there are significant error rates in the sequencing as compared to Sanger, up to 2%. In Sanger, it is up to 0.1%, the error rate. So, and also the bioinformatic, although it is more robust, still you can miss during the filtering phase. Then there are the practical challenges in the clinical setting, especially with our knowledge surrounding the genetic, identifying the patient and appropriate test for selection, dealing with the report, especially when you have a VUS or multiple variant that have been identified in the same patient. How do you counsel the patient? And the added problem is, suppose they want to plan the next pregnancy. How do you counsel in the antenatal? So all this requires the help of clinical geneticists, and also counseling and consent of not only informing the utility, but also the limitations and risks, which I have so far alluded to in many of these cases, that needs to be informed. And also the probability, like in one case which I handed out, which I highlighted, where you might need to screen the immediate family or the extended family members, especially when you get a VUS, you want to know the segregation. And so you need to screen the family, which may not be very easy. The family may be resistant to undergo this for various reasons. And also, although the costs have come down very significantly, it's still costly, especially for this lower social and poor economic class. So you really need to know the cost-benefit analysis and the risk-benefit ratio while ordering a test. For example, suppose you have I'm not taking a glomerular of HUS, it's a typical HUS, anti-CHF antibodies are negative. The patient does not have any plan for transplant or anything like that. Why would you like to do? And the patients are poor. Apart from an intellectual satisfaction, it is not really going to help the patient, especially when they have to loan that money and do that genetic testing. So really, we need to also understand the circumstances of the family when we are ordering the testing. So in conclusion, there are genetic etiology in subgroups of glomerular diseases, chiefly the podocytopathy, basement membrane disease, and HUS, and C3 glomerulopathy. And doing a genetic testing is useful for not only providing a specific diagnosis, but for treatment decisions, planning transplantation, and antenatal counseling. but we need to be aware of which test to choose and also the limitations and the risks and the cost implications. And most importantly, this genetic testing in the current age is not a static test. It's a dynamic, like I said, with more and more genes being discovered, with better way of bioinformatic analysis. We have always a chance to go back into the same genetic test that has been done to have a relook and see whether a variant can be identified. But what frequency we need to go back and relook, whether every 6 months or every year, is not very clear. Thank you for it.
Thank you so much, sir. Thank you for covering all about genetics, and it's important in the management of glomerular disease. Thank you so much, sir. It was excellent talk. Namalva, sir, you have any other comments to add on, sir?
That was a beautiful talk, Ma. You took us from the very beginning of genetic medicine, the errors that can happen, the various methods of screening, and finally the advantages and disadvantages of genetic screening. It was an excellent presentation, Ma, and a very comprehensive one also.
Thank you, sir.
Yes, thank Dr. Anil. Ma.
Thank you, sir.
Next, we'll have the polling session. I request Namalva sir, Susan madam, and Anil sir to kindly hold on. We'll have the polling session for 10 minutes for the participants, and then we'll take up the question and the answer section.
I'm sorry, I couldn't contribute the questions. Sorry for that.
No, that's okay, sir. I've added the questions. That's not an issue. So the instructions for the polling session is, I request all the participants to enter the proper...
Please excuse me, Ma. Kaliman, I have a small commitment.
Yes, sir.
Please excuse me, Ma.
Sure, sir. Okay, fine, sir. Thank you so much, sir. Thanks for all the input, sir. I request all the participants to enter the proper email ID and contact numbers so that we have a better follow-up. And we have already done with 3 polling sessions. We are into the 4th polling session, and each polling session will have 10 questions. And out of 10 questions, you will have 3 star questions, and star questions is used for in case of time. And cumulative polling session is 7, and only trainees are allowed to participate. And we'll have the questions now. We are closing the polling session. We'll take up the questions now. Susan madam, Anil sir, you're there, sir? Susan madam and Anil sir, you're there, sir? Anil sir?
Can you unlock? Okay, thank you.
Susan madam, you're there? Yeah, we'll take up the questions now. So the first question is, minimal change disease is all about T-cell involvement. Why there is no role of ATG in resistant cases? I think this question is towards Susan madam. Susan madam, can you please switch off your video so that the audio is better heard? Yeah, we are but it is buffering, ma'am. Can you switch off your video? Can you switch off your video so that your audio is better heard? We are able to hear you, ma'am, but it is... Yeah, ma'am. Can you switch off your video so your audio will be better heard? Yeah. Shall I read out the question again?
Yeah.
In minimal change disease is all about T-cell involvement.
Can you hear me now?
Yeah, I'm able to hear you now, ma'am. It's audible.
Yeah, okay. Can you hear me now?
Yeah, I'm able to hear you, ma'am. You're well heard now. I'll read out the questions.
Thank you. This
in minimal change disease,
anti-thymocyte global. Yeah.
Yeah. Why it can't be used? That is a question raised.
See, all the treatment, whatever we are using in minimal change disease, as well as focal sclerosis, nephrotic syndrome per se, is all time tested and have undergone trials, and that is found to be useful. Actually, there is no literature that reduces antithymocyte globulin in steroid-resistant minimal change disease at all. So there are no reports that are coming. The ATG is the molecule that is used in the induction therapy in difficult transplants as well as following rejection episodes which are steroid resistant. So ATG as a molecule is not tried in trials, and so we have no idea regarding whether it will be beneficial at all.
Okay. It has never been used here. What would be the reason for less than 3 years as a predictor of steroid resistance when we consider this age group to be atypical for primary nephrotic syndrome, who are supposed to be steroid sensitive usually?
Yeah, less than 3 years is actually the younger age of onset. It is found that there is a higher percentage of genetic nephrotic syndrome as the age is going down. Actually, it is 2 to 6 years is the typical age of onset, and less than 2 years you get a higher percentage of steroid resistance and a higher chance of having a genetic nephrotic syndrome. And so the immunology, we consider it as older age of onset may be associated with more difficult nephrotic syndrome.
Okay.
Possibly
the next question. Yeah, ma'am.
Higher chance of having a genetic nephrotic syndrome may be there.
Okay. And so we'll move on
just
to the
to
next
add to
question.
that,
Yeah.
so,
Anil,
so the predictor of
you have
steroid
to add a
resistance
little more on
is
that.
for
This
is
age
for
less than
those
2
the
years or
likelihood
3
of
years
genetic.
cutoff.
Yeah, it's a likelihood of genetic etiology, but overall, if you see, 30% of them have a genetic etiology. In the younger children, it may be a little higher, but it is among those who are steroid resistant. Now, steroid resistant is seen only in 10 to 20% of the nephrotic syndrome. So the overall genetic burden, if you see, is much lower. So, and steroid sensitivity is the norm in those younger children.
Okay. So we'll move on to the next question. For proteinuria treatment and steroid-resistant nephrotic syndrome, why we should decide whether ACE or ARBs? I ever read about we can have combination of ARBs and ACIs and CKD for proteinuria.
Actually, in the long time back, there was a trend towards combining ACE and ARB for reducing proteinuria in CKD, but that is totally given up because a combination of ACE, ARB in trials have found to increase the mortality due to cardiovascular disease, and also the combination is found to be detrimental for the overall outcome. So that combination is totally given up. We will be using either ACE or ARB. And in steroid-resistant nephrotic syndrome, see we can think of giving ACE or ARB, but ACE inhibitors may be associated with more chance of having cough and bradykinin-related side effects. So it is actually ARB or ACE is more ARB may be used in trials. So you can choose between ACE and ARB. There is no problem. There are studies for ramipril-based studies as well as this losartan-based trials are there. So there is actually no advantage of giving one over the other, but not to use a combination.
Okay. The next question is it mandatory to do renal biopsy before giving CNIs? Indications of giving lipid-lowering agents.
So this question is actually under a lot of globally now, whether we should be doing a biopsy prior to CNI, whether knowing that it is minimal change disease or FSGS is going to make a difference in the outcome. So possibly as the years go by, we may reach a time when people will be telling that more genetic studies and less histology in steroid-resistant nephrotic syndrome. So before giving CNI, doing a renal biopsy may give you an idea. For example, if you are dealing with minimal change disease, the overall outcome may be better with CNI compared to FSGS. So prognostication point of view, it may be good. But overall, because if you are having a baseline idea regarding the tubulointerstitial involvement that is already there, all of us know that interstitial fibrosis and tubular atrophy can occur secondary to ongoing proteinuria, especially if it is high-grade proteinuria. And also the CNI can also induce a tubulointerstitial damage. So if you are having a baseline biopsy showing that the tubulointerstitium is reasonably preserved with CNI, though the striped interstitial fibrosis is more definitive for CNI toxicity, it helps you to actually, from the point of view of explaining to the parent that the drug is not causing, or it is the disease that is causing, a baseline biopsy may be beneficial. But we may reach a time when it may not become a mandatory indication to do renal biopsy before giving CNI. Indication for giving lipid-lowering agent is, all of us, this guidelines are recommending lipid-lowering treatment only for steroid-resistant nephrotic syndrome. And even though we know that even dependent and frequent relapses, because the dyslipidemia may take time to come down, and these children may also be at risk of a long-term dyslipidemic internal milieu, but there is no guideline to support the treatment with lipid-lowering agent in children who are steroid dependent or frequent relapsing, who require a lot of immunosuppressive treatment and a lot of nephrotic internal milieu is there. So the definitive indication is steroid-resistant nephrotic syndrome, and the lipid-lowering drugs that are used as this atorvastatin is used, especially the cutoff age group now is 3 years. And we will be looking at the lipid profile. If the LDL cholesterol is more than 130, definitely there becomes an indication to start atorvastatin and other lipid-lowering agents. Okay.
Thank you so much, ma'am. The next question is why there is no role of plasmapheresis in primary FSGS?
See, the primary FSGS, as we have already presented, it may be due to this immunologically mediated disease, or it could be a genetic disease. So possibly we will be doing genetic studies to rule out a genetic FSGS. And if genetics is negative, then we presume that it is an immunologically mediated. And plasmapheresis is going to be beneficial in the permeability factor associated, circulating factor associated disease, now CFD. So whether it is a permeability factor mediated disease, or whether it is with this immunological but not associated with permeability factor, as of now we are not able to delineate between that. So see, when you are doing a transplant in a child who had an FSGS which has progressed to ESRD, at that point of time, assuming that it could be this circulating factor mediated, we will be doing a preemptive plasmapheresis. That is one thing. Second thing is, if the child had a recurrence following a transplant, and the graft is lost because of the recurrence, and you're going for a second transplant, definitely there become an indication for giving plasmapheresis. Other than that, for resistant FSGS, because we are not sure whether it is this or that, as of now, there is no indication as per the guidelines to do plasmapheresis in resistant FSGS.
Okay, ma'am. And a word about Mendoza regime at present. Are we still using Mendoza regime at present?
We are not using Mendoza regime at present. It is already given up because lot of methylprednisolone was given. It was given. Multiple doses were given. Then it was given bi-weekly, then weekly, then so many doses, and ultimately the child will be having not only the response may not be there, plus the steroid side effects and immunosuppression that is going to be such a torment for the child that Mendoza regime is already given up. And even methylprednisolone, giving 3 doses of methylprednisolone in children who are steroid non-responders at the end of 4 weeks is also plus or minus in most of the, either you can think of giving or not giving, but continuing for the next 2 weeks with oral prednisolone is also considered as okay. And methylprednisolone regimes, Mendoza is totally given up, but methylprednisolone regimes are now there for steroid-resistant nephrotic syndrome. When you are giving a triple drug immunosuppression, as in a post-transplant scenario, you will be giving methylprednisolone or oral prednisolone plus CNI plus MMF. Such regimes are being used in certain trials and found to be producing some amount of additional benefit in the form of a response. But how much sustained it is, and such triple drug immunosuppression utilizing methylprednisolone as one of the drug is also associated with lot of side effects in the form of this resistant infections and as well as occurrence of malignancy. So as such, the Mendoza regime and prolonged methylprednisolone dosing is not recommended now in steroid-resistant nephrotic syndrome.
Okay, thank you, ma'am. That answers the question. Next question is to Anil, sir. What is a rapid genome sequencing? Are we near a time when we can get the genetic test done like other rapid bedside tests? Example, the latest report of infantile encephalopathy.
So rapid genome sequencing refers to a quick turnaround of the results, where now you wait for at least 4 to 6 weeks or sometimes more to get your results. Here, you're trying to get it within a week with confirmation of the variant. And generally, it's used in the setting of critically ill, and mostly in the neonates, and to some extent in the critically ill child in the ICU. So, there has been some reviews that have looked at the utility of this, but they have not made any definitive conclusion whether a rapid genome sequencing does help. It does help in some situations, especially like in neurological disorders, but in many, it just gives you a diagnosis without any implication on the management. From a renal perspective, I don't know whether there are any situation where we'd like to have a immediate diagnosis. Yes, maybe when you're trying to start a CNI in the steroid resistant, it'd be good if you get a quick result, but you could always do a genetic if the child does not respond to CNI. So I mean, we don't use it in a nutshell. We don't use it in brief. We don't use it in renal diseases.
Okay, and the next question is again to Anil, sir. When we say as reported variant, does it imply reported with functional look of variation, or a mere case report or a case series with no functional analysis is fair enough?
So when we say reported variant, it is reported in various in the literature or in various databases, and it could be a combination of both. I mean, it's just it is noted in a few patients of a particular phenotype, and it could be combined with additional evaluation for the variant using various experimental or in vitro assays. The second point is a good point. I mean, so we have many diseases, especially with podocytopathy, where the particular gene variant or the gene involved has been described only in one patient so far, and that has been included in sequencing. So many of the genes that have been included in many of these panels do not have robust data to associate it with a particular phenotype, and that's where whenever you get a disease variant in a very gene that you've not generally heard of associated with the disease, you need to consult the lab which has done it, or a clinical genetist, or look into yourself, like how confident you will be in attributing that particular variant to the disease. So yes, there are a lot of variant genes that are associated with various glomerular diseases that do not have a robust correlation.
Okay. And the next question is which website or software we can use as a clinician to assess pathogenicity of an intronic variant or deletion?
Now, I mean, I'm not sure whether it is intronic or exonic, because generally what we look at is the exonic regions. You look at intronic variant in only one situation, that is identifying as splice site variants. Generally, you don't look for intronic variants in the deep intronic variants. You generally don't look for that. You look for splice site, either +3 or -3. You look for those, and there are a lot of software. There are at least 5 softwares that are available to identify these variants. But otherwise, in a clinical setting, you don't generally look for deep intronic variants.
Okay. The next question is, why do only some patients develop IRGN? Has it got anything to do with genetics? Does IRGN recur in the same individual?
Okay, so in genetic in general, there are 2 forms that you look at. One is monogenic forms, where there are defined gene causing a pathology. Then there is other set called genetic susceptibility, where just merely the presence of a variant in a particular gene does not lead to the disease. It needs others. It may be additional modifiers or environmental factor to trigger. So, so that same case could be with other non-monogenic form of glomerular disease, like it could be an IgA nephropathy, it could be a membranous, it could be even an infection-related glomerular nephritis. So that this question applies to all diseases, isn't it? I mean, even if you take an enteric fever, you will ask why is that even if they're living in the same and drinking the same source of water, one gets, the other doesn't get. So there is definitely a genetic susceptibility mapped to various HLA genes that have been associated in various diseases, including different types of glomerular diseases. So the IgN recurring is an interesting question, because what has been found is that generally IgN, we say that infection-related IgN, especially post-streptococcal, which I'm referring to, do not recur. But if you have a NPLR deficiency, these patients have been found to have a recurrence.
Okay, thank you, sir. And the next question is to Dr. Susan. A 9-year-old boy, initial steroid-resistant nephrotic syndrome, started with CNIs, achieved complete remission within 6 months of CNI therapy. What will be the further plan? Should CNI be stopped before 24 months? Should CNI be continued for 24 months and then stopped suddenly? And the next option is, should CNI be continued for 24 months and then be stopped with a tapering dose?
It's actually, this is a very practical and nice question. The guidelines are actually not recommending the total duration of therapy or the trough levels that have to be maintained in maintaining remission in these children. So the recent IPNA guideline which has come is, you will be giving CNI for 6 months. It may take 6 months for assessing the response to CNI. By 6 months, if there is no response to CNI, you take it as steroid and CNI resistant nephrotic syndrome. That is a multi-drug resistant nephrotic syndrome. So those patients we will be taking, let them be apart. And so this is here is a child who had attained complete remission within 6 months of CNI therapy. So should CNI be stopped before 24 months? So the guideline is telling that at 6 months, if you get a good response, you can continue till 1 year, and then you can reduce the dose of CNI. You reduce the dose of CNI, and the trough levels are not mentioned, but usually what we maintain is, we maintain a trough level around 100 of the cyclosporin, and tacrolimus we will be having around 4 to 7. Okay, so near 4 you can keep, and for cyclosporin you can keep it around 80 to 100, near 80. And so that is, again, no guideline is recommending. This is what we usually follow. And the children usually will maintain remission at lower doses of cyclosporin or tacrolimus, and then you have to continue up till 24 months. In between, if there is a relapse, you have to restart steroid, and the relapse will be usually steroid sensitive. And then you again come down on the dose of steroid and try to stop the steroid and continue on CNI. You can add MMF, and the IPNA guideline is telling that at the end of 24 months, you taper and try to stop the CNI, and you can switch to MMF. But practically, when you look at it, with years of whatever we are using cyclosporin or tacrolimus, we have seen that these children usually will be continued, and if you try to stop it abruptly, they definitely relapse. You taper it and stop it, also there is a higher risk of relapse. So possibly you will have to switch to another drug like mycophenolate mofetil, or you can plan giving rituximab at a later date if the child is going for a relapse. So we are having this rituximab also in the armamentarium. So there are no definite guidelines as to the duration of CNI therapy, how to maintain the trough levels of CNI, or when to stop the CNI. So if we are stopping CNI, trying to stop, it should not be stopped abruptly, but it should be stopped slowly with tapering of the dose and slowly going over and stopping the CNI. Usually there can occur a relapse following CNI stopping. So is there any another question?
In case if we switch
if the
over
response
to...
Yeah.
No, ma'am, like in case if we switch over from tacro to mycophenolate, and so how long do we continue mycophenolate then?
Again for 2 years. See, usually it is mentioned as you have to continue for 1 to 2 years, is that usually said. But most often these children will need some drug to maintain them in remission.
Okay.
So you will be lucky if you can switch to MMF and they keep maintain remission.
Okay.
And CNI responders, usually they may become more steroid sensitive in the subsequent relapses. That is also something that we observe.
True. Okay, ma'am. Thank you so much. And the next question is to Dr. Anil. What is the cost of NGS and MLPA in India? Any government of India lab where cost is a bit lower?
So the cost of next generation, or whatever you call it, as massive parallel sequencing, has definitely come down. And as I've said, there are generally ordered two type of NGS-based testing. One is a targeted panel. The other is a clinical exome sequencing, where you map only those 400 genes which are mapped to a known disease, and very rarely the whole exome sequencing. Many of the vendors I know that I'm aware that are offering whole exome itself in lieu of the clinical exome. So the cost of a targeted panel will roughly be around 15,000 rupees. The cost of a clinical exome is around 18,000. Like I said during the talk, the cost difference is not much because you're using the same process of preparing the samples, the libraries, and the same, the instrument to run the sequence, the sample. So that, and this way the companies are saving the cost, and that's why they're able to offer these tests at a lesser cost. The whole exome is a little costly. It comes around 35 to 40, I think, around close to 35,000. And whole genome, which generally is done on a research basis or in a collaborative way, costs roughly around 40 to 45,000 rupees. And generally that is not used in clinical testing. MLPA is used whenever you think of large deletions or copy number variations, typically that in HUS, and that costs around 6,500 to 7,000 rupees.
Okay. Thank you, sir. And the next question is to Dr. Susan. Can we use IV cyclophosphamide in place of oral in case of FRNS?
Of course, we can use. There are trials which have come out, and IV cyclophosphamide is actually, and oral cyclophosphamide are good in frequent relapses compared to steroid dependent. But both the groups, actually, this drug is effective. And IV cyclophosphamide given as monthly pulses, 6 doses, 500 milligram per square meter body surface area given as an IV infusion is going to be reaching the final cumulative total dose that we will be giving will be less when you are using IV cyclophosphamide compared to oral cyclophosphamide. Another advantage is IV cyclophosphamide is beneficial in patients whom you think that they may be non-compliant with oral therapy, which you will have to be administered at home, while this is in the hospital, and you're sure that the drug is being reached, and the response you can assess better. Another, any drug that you're using, there are pros and cons for that, and the disadvantages of IV cyclophosphamide is more higher dose that we are giving. IV infusion can be associated with more bone marrow suppression, which usually the total count may drop by around 7 days, but usually will come back by 14 days, it will come back. And hemorrhagic cystitis can be a problem, especially when you are giving IV cyclophosphamide. There is a risk that the child may start vomiting and may not be able to maintain good hydration. So you have to maintain good hydration by giving IV fluid, then you have to give antiemetics, and you have to keep the child in the hospital for at least 12 hours so that the child is not developing persistent vomiting. And it has to be administered in the morning hours, so that the metabolite acrolein is actually having a lesser time of contact with the bladder mucosa, and good hydration is ensured so that the hemorrhagic cystitis can be tackled. So definitely there is a role of IV cyclophosphamide. In the recent ISPN guidelines also, this IV cyclophosphamide is mentioned in place of oral in frequent relapses as well as steroid dependence.
Okay. The next question is the use of anti-hyperlipidemic therapy only in SRNS or to be used in FRNS or SDNS?
So the guideline is... Yeah.
The second part of the question is, what about atorvastatin with CNIs as both metabolized by CUTP? What is the best option to be combined with cytochrome P? And what is the best option to be combined with CNI?
See the dyslipidemia management with cholesterol lowering agent is guideline is only in SRNS, whereas FRNS and SDNS, even though we know that these children are also, because of the multiple relapses, they are also at risk of having dyslipidemia. And we have done actually one study which showed that at the end of 3 months also, in a nephrotic syndrome relapse, the cholesterol which was high was less but remaining still high at the end of 3 months. So possibly it may take 3 to 6 months for this lipid to become normal in a child who is having nephrotic syndrome, even if he is a responder. So think of a situation when the child is having more than 3 relapses in 6 months, or more than 4 or more relapses in 1 year. The most of the time the child will be dyslipidemic. So when you think from the practical point of view, there is dyslipidemia in FRNS as well as SDNS. But the long-term risk of this is not actually studied, and guidelines are not there for starting the cholesterol lowering drug in the pediatric age group. The problem is this atorvastatin. There are statins, use of statins in children. There are actually the approval from FDA and trials are not there. So we can use that only with guideline as in SRNS. So as of now, we will be using it with the guideline recommendation only in steroid-resistant nephrotic syndrome and not in frequent relapses or steroid-dependent. Second part of the question is atorvastatin with CA9. Both are metabolized by cytochrome P450. We know that not only nephrotoxicity, there is hepatotoxicity is also associated with use of CNI as well as atorvastatin. And so we have to, if we are combining these two medications as occurs in SRNS, we have to monitor the OT and PT periodically. And if the liver enzymes are getting elevated, then we have to stop atorvastatin for the time being. And because we don't want the child to relapse, we might have to continue CNI. And atorvastatin is also associated with muscle enzyme elevation as well as muscle soreness, and sometimes rhabdomyolysis can also occur with atorvastatin. So when we are using, we have to monitor these and we should know that such complications are there. Best option to be combined with CNI is usually we will be giving atorvastatin is the molecule that is commonly used in children because we are having some experience with that molecule. So we do give the dose recommendation as actually there is milligram per kilogram and all is not there. So we will be giving around 5 milligram in children who are more than 3 years. You can go up to 10 milligram. That is what, this is all empirical. This is not guideline. It is not mentioned in books. So this is actually the experience that I am telling from my experience.
Okay, thank you so much, ma'am. I think we are exceeding time. Can we skip the last 2 questions, or is it okay to take up the questions? We have almost 9.
Yeah, you can. We will just finish it. I will fast finish. Yeah.
Okay.
Rough level is subtherapeutic. The rough levels are subtherapeutic, and if the patient is in complete remission, there is no need to increase the dose because we know that the child is maintaining remission with a lower dose. Unless there is a relapse, there is no indication to increase the dose, because some children, it is individual based. Some children may require a higher dose of CNI, while some children may not require that high. Especially the Indian population, the metabolism may be a little different from the Western population, that our levels of drug may be maintained at even lower doses of drug, and our response also may happen at subtherapeutic. So if the trough level is subtherapeutic and patient is in complete remission, there is no need to raise the dose. You can continue seeing.
The next question is, why do we not think of repeat biopsy in transplant patient on CNIs except as a protocol at some centers, while we suggest in those with 2 to 3 years post CNIs in nephrotic? Is it merely due to the available alternate drugs, or if so, in a tough SRNS, can we continue with clinical monitoring alone?
See, the problem with the transplant kidney is that the patient is having only one kidney which is functioning. And any complication that is happening following the biopsy, the patient is going to lose that single kidney that is functioning. That is the most important. Second thing is, we know that the transplant patient on CNI, if the renal parameters are holding and CNI levels are maintained, actually things are moving good. And why do you want to subject the patient to a procedure which can be associated with some complication when there is really he is stable and going on? Whereas in the nephrotic child who is having a normal GFR, actually we want to protect the child from the impact of this drug, which itself can produce long-term toxicity and chronic kidney disease because of the interstitial fibrosis, striped interstitial fibrosis that can come up. So it is not only that available alternate drugs are there, that may also be one factor. And so in a tough SRNS, clinical monitoring alone may not suffice, because you should not be producing an ongoing renal damage, and there is also litigation problems can come up if at a point of time the patient is slowly developing a reduction in GFR, and the implication is that it is due to drug and not due to disease. So in a child who is CNI responding and maintaining remission, what is usually observed is the child who is responding completely, the patient remaining in complete remission, usually they tolerate the drug. But long run, child, long years, how it is going to affect and whether we need to withdraw, these things we can make a decision only with protocol biopsies. So it is better to do.
Okay. Thank you so much, ma'am. Thank you, Anil sir. Thank you, Susan madam, for patiently answering all the questions. Though we have exceeded the